القائمة تكون موجودة. Okay, we can start, huh?
تفضل دكتور. تفضل دكتور.
Okay.
بجوز ينضموا خلال الراوند.
Okay.
يعطيك العافية دكتور.
Okay. We have two groups, isn't it?
مظبوط دكتور.
Okay. The total number is expected to be how much?
30.
30. Now 23 are there. Okay. So we can wait for a few minutes for that, but for the time being, let us start. Actually, your name's in front of me, and you know I am Dr. Adnan, urologist. So this is the first time for us to meet in this way, which is unlikable. Anyhow, our topic for today, we will have a patient, and this patient is 40 years male patient with right flank pain. Okay, so I need Khalid Daragma to take the brief history from me as I am the patient. Start, Khalid.
سامعني دكتور؟
Yes.
Okay. Take full history.
Yes. Right flank pain with history of urinary stones. I am the patient. Please speak to me.
Okay.
I will give you 5 minutes.
Okay.
Okay.
I will ask first for the name.
Ask. Carry on.
Okay.
Carry on. Just as you are seeing the patient.
اوكي. لو سمحت باخذ اول شيء اسم. شو اسمك؟
الاسم محمد ابراهيم عبد الله.
محمد ابراهيم عبد الله. اهلا، انا خالد رغمي، طالب طب سنه رابعه. فيني اخذ منك السيره المرضيه. وين سكان وين محمد؟
سكان مدينه اربد.
وكم من عمر؟
40 سنه.
40 سنه. متزوج؟
نعم، عندي 3 اولاد.
عندك 3 أولاد، ما شاء الله.
الله يسلمك.
محمد، شو بتشتغل؟
أنا بشتغل تاجر.
تاجر، أوكي تاجر. ساكن بأي منطقة؟
المنطقة الحي الجنوبي.
الحي الجنوبي. طيب شو جابك على المستشفى اليوم؟
جابني ألم شديد بالخاصرة اليمنى.
بالخاصرة اليمنى، تمام.
نعم.
الوجع إمتى بلش؟
الوجع بلش قبل ساعتين.
قبل ساعتين وإجيت على المستشفى.
وأجيت على المستشفى، ما قدرتش أتحمل الألم وأجيت على المستشفى.
وأنا
على الطوارئ؟ أجيت على الطوارئ. نعم، أجيت على الطوارئ. وأنا عندي حصى من زمان.
عندك حصى؟ أوكي.
من زمان.
من زمان. طيب الألم وين كان بالضبط؟ على اليمين؟
الألم بالخاصرة اليمنى.
بالخاصرة اليمنى. كان الوجع يروح على أماكن ثانية ولا بس بالخاصرة اليمنى عندك؟
بالخاصرة. ألم شديد.
بالخاصرة. أوكي تمام. هلا الوجع كم شدته كان؟ يعني وجع ألم
شديد
شديد
يعني ما قدرتش أظلني جالس شديد بالمحل تاعي، وأجيت على مباشرة على الطوارئ.
طيب الألم اللي قبل ساعتين كان يجي قبل هيك ولا بس هالأول مرة يجي؟
لا، كان يجي. أنا قبل 3 سنين كان عندي حصى.
كان عندك حصى قبل 3 سنين، وشو سويت منها؟
رحت على الدكتور وعمل لي فحوصات وأعطاني علاج ونزلت الحصوة.
ونزلت الحصوة وهلا رجع الألم؟
هلا إجا ألم شديد.
طيب الوجع كان يتحسن مع أي حركة أو أي قعدة؟
ولا
بس بالقعدة كنت تسوق؟
ولا في أي بوزيشن مريح له.
ولا أي بوزيشن. تمام.
ولا أي بوزيشن.
أوكي. كان يختلف بعد الوجع؟ كان مثلا تلاحظه بوقت معين أو يختلف مع الأكل؟
لا،
أو لا
فجأة إجاني الألم وجيت على الطوارئ.
فجأة إجا لك ألم. تمام. كم مرة باليوم كان يجي لك الألم؟
هي أول مرة بيجي من 3 سنين.
أول مرة من 3 سنين. تمام. أوكي. اول مره وبعدين اجيت على طول على الطوارئ. طيب انت عندك امراض مزمنه يا محمد؟
لا، بس الحصى.
بس الحصى. وبتاخذ ادويه لها لسه ولا وقتها
لا
اخذته؟
لا لا، باخذش ولا شيء.
ولا شيء بتاخذ لها. طيب انت وقت ما عمل لك الدكتور عمل لك ما عمل عمليه، بس اعطاك ادويه
لا، اعطاني علاج ونزلت الحصوه.
ونسبة الحصوة. تمام. طيب بس بدي أسأل شغلة كمان محمد، أنت لما
تفضل.
كنت تروح على الحمام أو إشي كنت تلاحظ مثلا في دم عندك بالحمام، في تغير بلون البول، ولا ما كان في أي إشي يتأثر؟
وقت الألم هذا رحت على الحمام وكان لونه أحمر.
كان لونه أحمر. طيب
نعم.
سؤال، متأكد إنه كان لونه أحمر ولا كنت أنت تشوف فيه دم؟
لا، هي لون أحمر، ممكن دم.
ممكن دم، مش متأكد يعني. طيب كنت تشوف فيه تجلطات بالبول ولا لا؟
لا.
ما كان فيه. طيب
لا
واكلت انت قبل بيوم كنت تاكل، او اليوم نفس اليوم اكلت اي شيء مثلا زي شمندر، بتاخذ
لا
اي
لا
ادويه؟
لا لا
ولا شيء.
ولا
يعني
شيء.
السبب مش من اكلك او شربك.
لا.
طيب كان في الم عند التبول؟
كان في حرقان.
كان في حرقان. اوليه البول ولا طول الفتره؟
ما بهيك بالبداية، بس شيء بسيط.
بالبدايه شيء بسيط. تمام. طيب وما كان في اي تغيرات ثانيه، اي اعراض ثانيه تصير عندك؟
مثل
عامة يعني لكل الجسم غير الوجع اللي كان عندك واللي عند التبول، هل كان لاحظ أي شيء ثاني؟
شعور بالمراجعة هيك، أو كنت ممكن هيك بدي يعني نفسي ملعب، ممكن أراجع.
ممكن تراجع، كنت تحس حالك أمراض لك وعيان يعني؟
آه
تمام. طيب سؤال أستاذ محمد. طيب محمد، بتاخذ أدوية شيء ثاني ولا شيء
لا.
دلوقتي؟ ولا شيء.
آه.
عندك حاجة ثاني بالعيلة عندهم حصى، ولا كان عندهم هيستوري يعني عندهم تصير معهم نفس الشيء ولا انت؟
مين بتقصد مثلا؟
يعني مثلا انت مثلا مثلا ابوك امك اي حدا
أها.
بالعيله كان في يكون عندهم؟
جدي كاين عنده.
كان يصير عنده كثير تمام. طيب عندك قبل هيك في عمر كنت زرت المستشفى عندك عمليات ثانيه غير او اي شيء غير الحصى؟
لا.
ما في شيء. طيب تمام. انت مأمن محمد؟
لا، أنا تاجر، عندي
تاجر
تأمين
ما في
خاص.
تأمين.
لا.
تأمين خاص.
مم.
والراتب في حدود كم يعني؟
بستورة الحمد لله.
مسطورة الحمد لله. تمام. طيب عندك هو بس هيك هاي الدكتور يعني هيك these are the main things I would have asked for صراحة.
أوكي. أوكي بيان. You can continue. Do you feel anything deficient in the history taking? This is a renal stone. Patient, 40 years. So do you think that we need to ask any relevant questions rather than the questions asked by your colleague?
associating symptoms ممكن إذا fever إذا weight loss إذا كان previous attack من قبل.
Yes.
يعني إذا يعني من قبل صارت معه الحالة، يعني إنه صار في وجع أو إذا في بعائلته في same condition أو chronic illness.
Yes, he asked about this family history.
إذا عمل surgeries or admission من قبل.
Okay, إذا عمل surgery, what do you want to ask about?
إيش surgery ومتى عملها؟
Which type of surgery you will ask about?
ممكن الزايدة الدودية أو شيء زي هيك.
كمان.
يعني في حالة إنه صار معه obstructive jaundice من قبل أو شيء زي هيك، يعني إنه صاروا يعملوا عملية، أو الدراجز اللي هو باخذهم.
مثل إيش الدراجز اللي بدك مثلا تسأل عنهم؟
إذا باخذ أي
There are certain drugs. You see, there are certain drugs in this case we have to ask about.
ماشي بس هو عشان معه هيماتوريا ممكن أصلا إذا باخد ريفامبين إذا نسيت الدواء بالضبط.
No, our case is urinary stones. So relevant drug history related to the stone formation. This is the main thing which we would like to ask. The drugs which participate in crystallization of minerals or alter the urinary function to form stones. So these are the drugs which are meant to be asked about. So do you know any of them? Okay. Okay. So thank you very much. Faisal, you need to ask any different questions? Huh? Do you like to ask any other question not asked, which you think that it is related?
بالنسبة للأدوية
زي anything else you like? Any question? Patient, 40 years, male patient with urinary stones. What are the relevant things we have to ask in the history? Whenever we take the history of the patient of renal stones, what are the things we have to concentrate on?
Water intake مثلا.
The water intake. And so this is, we call it diet history. Isn't it?
Yes.
Okay. So in a diet history, what are the things you will ask about? You said water, fluid intake.
Yes.
This is nice. Anything else related to the food? Type of food?
بعرفش إذا الفايبرز containing foods لها علاقة.
I want to tell you this thing. You know what are the main composition components of stones? Calcium, isn't it? Calcium, magnesium, phosphate. The calcium, where it is abundant in which type of food? Milk and its derivatives, isn't it?
مظبوط.
So we have to ask about this. Do you take this milk and its derivatives frequently or not? So this is part of the diet history. Excellent. Anything else? Diet.
إذا بياخد مثلا مكملات غذائية كالسيوم أو معادن مثلا.
Yes, very good. So if he is sportman practicing some type of sports, very good. Anything else in the history you think that we need to mention it?
لا والله بس هاي.
Very good. Anybody else he can share?
دكتور ممكن drugs that cause عندك الستونز مثلا السيبروفلوكساسين الانتيبيوتيك we can think of الانتي hypersensitives الdiuretics مثلا لو عندنا
very good. So excessive intake of certain drugs like diuretics, furosemide, ciprofloxacin. Any drugs else? Very good.
دكتور في عندي
Very nice. So now the number with us is 25. So Muhammad, we can start now.
تفضل دكتور.
Okay. You see now the case with us is urinary stones. So this is a frequent, typical case which we present for the medical students. This is urinary stones. About 25% of our patients in urology are from this category. So in this category, we will strict to the history taking. So we taught you in the history taking that first of all, we have to introduce ourselves and take permission of the patient. This is well done by Khaled. Then we go for the personal profile of the patient. So the personal profile of the patient composed of name of the patient, and as we are dealing with stone formation, we need always the family name. Do you know why we take the family name?
لأنه في أمراض معينة بتيجي لفاميلي معروفين.
Because renal stones are of two categories. One is acquired and one is inherited. So we call it metabolic stones. So the metabolic stones, they have familial tendency. That's why the family name of a patient of urinary stones should be mentioned in the history taking. You got it, huh? So the urologist should know the family name of all of his urinary stone patients. This is all over the world. Because we have certain families in the society, they are prone for stone formation. And this has familial tendency. So this is one point not mentioned in the history. So we have to ask the patient, what is your family name? So the name of the patient, his family name. Then important thing among the personal profile of the patient is the occupation of the patient. The occupation of the patient, it's important to ask, is it indoor or outdoor? So if it is indoor, it means that the patient is not sustained to lose a lot of fluids, isn't it? If it is outdoor, so he might lose a lot of fluids. So he's more prone for stone formation. Anything else about the occupation is it sedentary, sitting position, or he is moving? If he is moving, this is better than being sedentary. So we believe that indoor sedentary are more prone for stone formation. Outdoor occupation also has the merit to form stones. Number 3 of the personal profile of the patient is the route of admission. Why we ask about route of admission, يا فيصل?
عشان تؤسس the case severity تبعتها.
Okay, Dina. Georges. محمد عربي.
نعم دكتور.
What is the importance of route of admission? Why we ask about route of admission in the personal profile of the patient?
To know how severe is the case in the patient situation.
You see, the case admitted through ER might be very simple, like abscess formation or just cut wound in the thigh, small cut wound, and it is admitted through ER. And a case of cancer, which is very dangerous, admitted through the OPD. So the severity of the case is not that thing. Who can guess why we ask about route of admission? Anybody? Anybody?
Maybe دكتور عشان
ممكن عشان إذا acute or chronic?
No.
دكتور يمكن
yes.
إذا الأورال يكون أعلى نسبة إنه يكون رينال كوليكس من الآي في.
Any other opinion?
To know maybe how much pain he is in.
Okay. The importance of asking about route of admission for 2 reasons. Number 1, we will decide type of investigation which we are going to do to the patient. The patient who is admitted through the ER, all of his investigation are supposed to be ready within minutes to hours. But a patient admitted through the OPD, the clinic, his investigation might take days or weeks or months. So the types of investigation. This is number one. Number two, prognosis of the illness and the medico-legal aspect of the case. So the case of ER has poor prognosis comparatively with a case of a clinic, because the case of ER, we are not going to do all essential investigation. Just we will do the primary investigation needed to interfere with the patient. So we expect that the prognosis is poor comparatively with the patient who is admitted through the OPD. Actually, in medicine, in surgery, in the medical life, we practice medicine in a medico-legal form also. That's why the medico-legal aspect of the issue is important, where the patient is admitted through the ER or the clinic. The patient admitted with ER, we expect poor prognosis comparatively with that one. So certain complications are allowed with a patient who is admitted through the ER, but not with patient admitted from the clinic. That's why we ask about route of admission for type of investigation and prognosis of the illness. So name of the patient, family name, now route of admission, occupation of the patient. Now other items of the personal profile also should be mentioned. But these are the important issues in the urinary stone formation. So something else, which is religion of the patient. Religion of the patient in urology in general is important to be mentioned. Some of you might practice medicine outside the Middle East. So you are prone to see a lot of people from different ethnies or different religions, isn't it? So what is the importance in urology to ask about this religion?
For example, عندنا Jehovah's Witnesses اللي هم شهود يهوه ما يقبلون.
Yes, yes, this is nice. But something more.
Some religions, they don't circumcise, basically.
Circumcision. Yes, the circumcision is practiced only by religious affairs, Muslim and Jewish people. So rest people of the world, they are not circumcised. So the religion is also important in urology. Now we come to this is the personal profile of the patient regarding this urinary stone. Then we come to the chief complaint. Now the chief complaint, we said that the patient had pain, isn't it? So how we go to analyze the pain of the genitourinary system? We ask about pain, certain questions. Number one, site of the pain, and number two is nature of the pain. So what is the question? If it is the problem or the pathology is in the kidney, what is the nature of the pain that we expect? The patient will tell us what is the nature.
Maybe colicky?
Colicky. Colicky, the colic is sudden severe. Sudden severe pain is urethric pain. It is not renal. So the urethric pain is like this, sudden severe pain, which is colic. But the renal pain nature is dull. So the patient will say, ثقل بالخاصرة. ثقل. This word, you will hear it a lot from all patients by different languages. So it is dull in nature. Who said this?
I did.
Dina? Arwa. Very nice, Arwa. Why, Arwa, this is dull?
Because you can't know where the pain is exactly.
Because the kidney is enveloped by gerotaphagia. So the pain is a stretching of this gerotaphagia. So the stretching of this urethrophagia is widespread around the kidney. So it comes like dullness. So the word used by patient, Ya Arwa, is dull pain, whatever the pathology of the kidney. Excellent. And it is in the flank, either in the right side or left side. Okay. Then we come to the urethric pain. The urethric pain, as we said, is colicky. Colicky. Now, the ureter is clinically divided into 3 parts: upper, middle, and the lower. 10 centimeter. So the upper one usually is referred to the flank. That's why you read in the book the term renal colic, isn't it? So this is old term and a misleading term. It was before the adventure of CTs and radiology. The precise one is urethric colic. Now, the middle urethric pain. We have right side now, isn't it? And the patient told Khalid that I have nausea and I tried to vomit. Why this happens, ya Khalid?
والله ما بعرف دكتور.
Very good. Arwa.
ما بعرف.
Okay. Anybody?
Maybe it's the same neurological nourishment.
Okay. I want to remind you with the anatomy. The ureter
is the
anatomically, yes?
The nerve connections between the kidney and the GI tract.
Okay. The ureter is passing down. In the middle part of the ureter, it is adjacent to the cecum, just near to the cecum. And in the left side, it is just near to the descending colon. Now, the urethric pain, there is obstruction in the middle part. This obstruction, the ureter tries to increase peristaltic movement to expel this obstruction. During this increasement of the peristaltic movement, the ureter sticks to the cecum. So it irritates the cecum. When it irritates the cecum, it will do paralytic ileus. And the same in the left side also. So it will do abdominal pain, nausea, and vomiting also. It is clear now? So it is paralytic ileus due to movement of the excessive movement of the large bowel. It will manifest as paralytic ileus, nausea, abdominal pain, and vomiting. So it is in the differential diagnosis of acute surgical abdomen. So it is in the differential diagnosis of appendicitis, for example, in the right side, and diverticulitis in the left side. Clear?
Yes. Yes, doctor.
Very good. Now, the lower urethric pain usually radiates to the external meatal orifice and the middle inner of the thigh, upper part. Now, the vesical pain, urinary bladder pain, how it is described by patients? It is suprapubic pain. And its nature, how is its nature described by patients? Arwa?
Stabbing ممكن?
Okay. Usually it is discomfort. عدم ارتياح. The patient will name it like this. It is suprapubic discomfort. Actually, this is uncommon for the vesical pain, except one case where the pain is severe. What it would be, يا داود؟
دكتور ممكن تعيد السؤال قطع الصوت.
Okay. The vesical pain, the urinary bladder pain, usually is discomfort. But in one condition, it is severe case, severe pain.
ممكن حالة infection, inflammation, cystitis.
Cystitis, discomfort.
دكتور ممكن
Yes.
femoral hernia?
No, vesical pain, urinary bladder pain. Urinary bladder, whatever the pathology, usually is discomfort. One condition, it is severe pain. The patient cannot tolerate.
Maybe cancer?
No, the cancer is usually painless.
ممكن يكون في بلوك بالفلو دكتور.
The thing is acute urine retention. Acute urine retention is due to any cause, whatever that one. For example, acute prostatitis, it might cause obstruction. Stone can cause obstruction to the posterior urethra, and there will be acute urine retention. So the acute urine retention is painful. The chronic urine retention is painless. So this is how we can differentiate between both of them. So this is the only case where the vesical pain is severe. Now, what about the urethral pain? How it is described by patients? How the patient describe urethral pain?
Maybe burning.
Excellent. They will describe it as burning, scalding in nature, burn-like. Okay. Now, for males, we deal with external genitalia as well. So the scrotal pain, how it is described by patient? What is the nature of this scrotal pain? Actually, for this scrotal conditions, we need another meeting for that.
It radiates to the abdomen. It can be felt. It radiates. It's like inner sharp pain, inner radiation.
Actually, the scrotal pain is variable according to the underlying pathology. It might be mild, moderate, or severe, according to the cause. If it is ischemia, for example, it will be sudden severe. If it is inflammation, it will be mild to moderate, isn't it? So this is, in general, we describe the genitourinary pain. We analyze it. Now, next item in the history taking of this urinary stone, number one, we analyze the pain. Number two, the other symptoms. The most important one, which you asked about, Khalid asked about, which is discoloration of urine, which is hematuria. So always mention it in its name, hematuria, dam بالبول. Next to this, we come to the other urinary complaints. And Khalid, he did very well with this. He asked about frequency, urgency, burning maturation, and the others. Now, there is something which is important, which is the systemic manifestation. The systemic manifestation in the cases of urinary stones coming to the ER is very important, which was not asked, isn't it? So what is the most important systemic manifestation we will ask about?
دكتور ممكن بحالة الهبر كالسيميا نشوف مثلا constipation أو ممكن نشوف joint pain بحالة مثلا gout أو بحالة pseudo gout.
You are Faisal?
داود.
The patient came to the ER with pain, and he told that I am known case of renal stones. Systemic manifestation, very important to be checked in the ER.
Maybe hypertension and tachycardia.
The major systemic manifestation is fever, infection.
دكتور ممكن انه ينقطع البث خلال اقل من دقيقه فانه بنرجع على نفس الرابط.
Okay. So the temperature is the most important. بدي ينقطع البث. سامعين؟
لسه هو حينقطع فجأة يعني لأنه ضايل له أقل من دقيقة مبين لي.
So the major systemic manifestation which we will check in the ER as the patient came to us like this one is the temperature. And let us wait to continue this item. Okay. But the number is 25, okay?
تفضل حكي.
Okay. Now the patient is in ER, came with this pain. The major systemic thing which we will check is the temperature of the patient. Why we check this?
An infection بتصير because في obstruction تبعت الكدني ستون.
UTI.
Because one of the complication is obstruction, and this obstruction might lead to infection, isn't it? So this infection will manifest as temperature, as fever. So what is in the mind to check this fever? There is something called systemic inflammatory response syndrome, which is composed of temperature, fever more than 38 or less than 35, then
chills, rigors,
heart rate more than 90, and respiratory rate, and white blood cells. We do CBC more than 12,000 or below 4,000. What is the importance of this? This is inflammatory response syndrome. And the presence of two of them is something we have to take alarm thing. Then we are afraid of septic shock. So then we will check the blood pressure of the patient. This is the primary survey in the ER. So the patient came to the ER. The first thing we are going to do for him is to relieve his pain, number one, then to check the temperature, pulse rate, respiratory rate, CBC of the patient. Two of them positive, take the blood pressure, rule out septic shock. See, this is the lab investigation needed for this patient. This patient came to us to the OPD. Okay? You are hearing me?
Yes, معك دكتور.
Yes, I need you to participate with me to be sure that you are listening to me. That's it. So this patient now, he is with us in the clinic.
Okay.
He is with us in the clinic. He is telling us that I am stone former, so we want to investigate him. What is the lab investigation we will do to this patient? The first lab investigation. You see, when he came to the ER, what was the first lab investigation done? The CBC. Why? Because we want to rule out infection. We want to rule out urosepsis. That's why we did for him the CBC, the first lab investigation. But if he is meeting us in the clinic, what is the first lab investigation we will order?
ممكن نفحص الكالسيوم دكتور اللي بالكلينيك نعمل الالتراساوند.
Lab investigation.
Okay. We can do 24-hour calcium test عشان الستون.
Okay. Anas Khawalda.
دكتور.
What is the lab investigation? Number one, you will do for renal stones in the clinic.
Ultrasound, دكتور.
Lab investigation, Anas.
Lab investigation, KFT.
Okay. Arwa.
ما بعرف.
Urinalysis.
دكتور باراثيرويد هرمون.
Dipstick analysis.
تامر
قصدك دكتور تمارا؟
تمارا.
ممكن اليوريك أسيد.
Okay. The first lab investigation, we will do the simple thing, which is the urine analysis. This is number one. Why we do this urine analysis? What are the things which we look for? This is a case of urinary stones with us. And the first lab investigation we are going to do is the urine analysis in the OPD. But you see, he is known of renal stones, came to the ER. We didn't go for urine analysis number one. We went for CBC because the CBC to rule out urosepsis, because the urosepsis is the most dangerous thing as an emergency for us due to a complication of a stone. Now, the patient in the clinic, we order for him simply urine analysis. What we look for?
Abnormal substances such as
pH.
glucose, proteins, abnormal concentration of
دكتور crystals.
One of the females, what she said?
pH.
pH of the urine. Arwa, you said this?
Yes.
Very nice. Why the pH?
Because I think some stones, they they prefer an acidic environment. وفي I guess ما أعرف صراحة بالضبط.
Very nice. Okay, this is the idea. You see, we look to the pH of the urine. We divide the stones into two types, acidic stones and alkaline stones. The acidic stones, usually they have metabolic disorders. So they are inherited, like uric acid stones, cysteine stones. These are the common acidic stones. So we look to the pH. The infective stones, it means that they are having alkaline urine. So the most important item of the urine analysis we look for in the urine analysis is the pH of urine. So this is number one investigation. Number two, investigation for stone formation in the OPD.
دكتور ممكن نشوف البيو ان والكرياتينين ليفلز؟
Number two is rule out infection, always urine culture. So urine analysis number one for pH. Number two, rule out infection. We said acidic stone, alkaline stone. So we want to prove it by the culture to prove there is infection or not. So because due to the stones, if you look to the microscopic urine analysis, you might see white blood cells. White blood cells is due to stones, not due to infection. So we rule it out by doing culture. So number one, urine analysis, and number two is urine culture. This is in the OPD. If the case came to the ER, we said, number one, we do CBC. Number two, in the ER,
dipstick analysis.
Lab investigation, which has importance.
Culture.
You see, we said that in ER, route of admission is important, type of investigation needed, and prognosis of the illness. A patient came to the ER with your history of urinary stones. We are afraid of the complications which might alter the life of the patient or the organ. So the life of the patient might be altered as the patient might develop septicemia, urosepsis. So it will affect the whole body. So number two, there might be obstruction to one organ, which is one kidney, maybe obstructed, maybe two are obstructed. So the obstruction. So we do number one, CBC as an emergency. Number two, we will go for renal function tests. We have to know about serum creatinine of the patient. And number three, we might ask for urine analysis just like this, and we will send urine sample for a culture, but the more important is the liver function test. For example, the patient was septic. He has fever and he has infection. So we will go for liver function test as a baseline because we might use strong antibiotics in their clinic, the same patient. We said, number one, we do urine analysis. We send for urine culture, and then we will go for renal function. And then what are the other things we will ask for lab investigation? As you mentioned, calcium level, phosphate level, phosphorus, oxalate, and the rest. 24 urine hour collection for these proteins and the minerals. Now, next to this, we will go for radiological investigation. Radiologically, what is the initial radiological investigation we do for a case of urinary stones known to us as this patient?
Without CT without
CT?
Listen carefully. The initial means number one.
Ultrasound, maybe?
There is a difference between initial or optimal. If I am asking you what is the optimal is different, or what is the initial radiological investigation?
KUB.
KUB, okay. What is KUB?
X-ray.
Yes. Arwa with me?
Oh, yes, with you.
Very good, Arwa. So this is a type of X-ray which is called KUB. KUB, it has factors to name a plain X-ray as KUB. Number one, that it should visualize the expected course of the kidneys, ureters, and the urinary bladder. This expected course, as you know, these structures are retroperitoneal, the kidneys and ureters. So in front of them is the bowel. The bowel has a lot of gases, isn't it? So we need to prepare the patient for this X-ray to be taken. So we have to give the patient castor oil a night before, and next day we will do it. This is number one. Number two, this X-ray, KUB, it will visualize 75% of urinary stones. They will be radio opaque, but 25 are radiolucent. So this KUB is not part of a routine. So a patient came to the ER. We will ask for him to KUB. He will come next day. So this KUB is part of the past. We don't ask for KUB only one case. Whenever we have patient with urinary stones and we did for him lithotripsy. After this lithotripsy, we can follow him with KUB. So this is the only place we ask for KUB. So the initial radiological investigation for urinary stones is ultrasound. The ultrasound is available, cheap, not harmful, and can give you the information which you need. So what are the informations which we need about the stone?
Site of obstruction, size of the kidney, shape.
Site of the stone.
Composition of the stone.
Size of the stone.
Number.
And effect of the stone. Site, size, effect. So these are the three things which we need. Where is the stone? How its size, and what is the effect of this stone? Clear?
Yes, clear.
Okay. Now, these three are important in deciding what is the next step to do for the patient. Now, the next question is, what is the optimal radiological investigation for urinary stones?
CTK.
What would be excellent? CT scan without contrast, plain CT scan. Clear?
Yes, doctor.
Okay. So the initial radiological investigation is the ultrasound. The optimal radiological investigation is plain CT scan. So 95% of the stones are radiolucent. We can radio opaque. We can see by CT scan. Just 5% we cannot see. And these 5% are among patients like, who knows, you mentioned this in the drug history, in the navel stones, the patient of HIV, protease inhibitors. So in this category, we might need CT scan with contrast. Now, we said that we will look for the site, size, and effect. What are the effects of stones on the urinary system?
Obstruction.
Obstruction. The obstruction, how it will manifest? Radiologically.
ممكن نشوف hydronephrosis
Excellent. What is hydronephrosis يا أنس؟
داود.
داود. What is the hydronephrosis?
بكون عندنا اليوريتر كثير مضخم اللارج لأنه بكون في عندنا obstruction موجود بسبب ستون فبين عنا. عادة هو ما بين اليوريتر بس ممكن بحالة الهيدرونفروسيس يبين معنا اليوريتر بسبب الريتنشن بالفلو تبع اليورين.
Okay. Anybody else?
وكمان وممكن
الكاليكس تبع الكدني
fluid in the
ممكن
kidney.
كمان بالكدني يبين معنا. بالكاليكس لما كمان تكون كثير enlarged.
Okay.
Swelling.
Scientifically, yes. Scientifically speaking, what is hydronephrosis?
Swelling of the kidneys.
Yes.
Swelling of one or two kidneys, or both of them.
Because urine بيتجمع جواتهم.
Okay. So the term hydronephrosis. Hydro means origin of the word. Hydro means water. Nephrosis, nephron. So the origin of the word from this. So if it is water, so it is aseptic. It is clean. So it is aseptic, dilated pelvic calyceal system, unilateral or bilateral due to partial or complete obstruction. So this is the definition of hydronephrosis. So hydronephrosis is aseptic. It means it is just urine. It is clear urine. It is not infected. So it will manifest in the X-rays, which we asked for as ultrasound or CT scan. It will be black. Imaging was black. So this is, we call it hydronephrosis. Now, what is the alarming thing to us is what is called bionephrosis, pus formation. Stones can do hydronephrosis in the beginning. This can be complicated with infection to be bionephrosis. So the clear one, the black, it will not be black. It will be internal echos, whitish debris inside. So this indicates pus formation. And we look to the parenchyma outside the kidney. It will be thickened. And sometimes with these stones, so we'll see the acoustic shadow of the stone, plus internal echos inside, and we might see also sometimes masses, growth. So these are the things which we look for in the case of radiological investigation for urinary stones. Nice. Now, the last thing which I want to take from your time is what are the general rules of management of the stones?
أول إشي بنشوف السايت تبع الستون والسايز تبع الستون.
We said yes,
هدول شغلتين.
size and effect. And
وهدول ممكن
effect of
يحددوا
the
لي
stone.
المانجمنت.
Yes. So what are the principles of management? According to this, number one, 90% of the stones are passable. They pass spontaneously as the size is less than 6 millimeter. So because the ureter can pass such stones. So most of the stones, they are passable spontaneously. So this is called watchful waiting. Watchful waiting. We will watch and wait for this to pass by encouraging the patient to increase his oral intake, isn't it? Next to it, we will come to the conservative management. What are the lines of conservative management as we mentioned? Ahmad. We said that we will do urine analysis and urine culture. And we said we have acidic stones and alkaline stones. So for the acidic stone, what we give? We want to make the pH of the urine near the 7. So alkalinizing agent. So if it is acidic stone, we will give alkalinizing agent. If it is alkaline, what we will give? We will do the urine culture, and according to this, we will give antibiotics. So antibiotics and alkalinizing agents. So this is part of the most important part of the conservative management. Then we go to the invasive management. Minimal invasive and non-invasive and invasive. So if the size is less than 6 millimeter, it is passing spontaneously. Now from 6 millimeter to 2 centimeter, what we will play with, what is the kind of management would be?
Shockwave therapy?
Something called lithotripsy. Lithotripsy. Fragmentation of the stones. So we have extracorporeal from the outside of the body. There is a special machine for this, so it will fragment the stones. So this is a day case. The patient will not be admitted to the hospital. He will come, he will take the session, and he will go home. So this is called ESWL, extracorporeal shockwave lithotripsy. We have intracorporeal, for example, in the ureter. So this is endoscopic due to the endoscope, ureteroscope, and laser fragmentation of the stone. If the stone is more than 2 centimeter to 3 centimeter, 0.5, there is something called PCNL, Percutaneous Nephroplethyatomy. There is one place where we do open surgery.
البلادر.
What is that? Stone.
البلادر إذا كانوا متجمعين بالستونز.
No.
الستونز بالبلادر.
No, there is stone which is called Staghorn stone. الحصى المرجانية. Staghorn stone. So in that stone, this is the only place where we open the kidney and remove that stone. You see, this is the history of the patient. So the history of the patient, always we concentrate on what? Number 1, name and family name. Number 2, occupation of the patient. Number 3, route of admission, because it will give us what are the expected prognosis of the illness, how we have to deal with it. Now, history of present illness, we said about pain, urinary symptoms, and associated systemic manifestation. This is very important to say that there was fever or no fever, chills, rigors. So this is very important to rule out systemic manifestation. Then we go to the past history. The past history of the patient. Post-medical, post-surgical, post-urological. What is the post-medical in the history of urinary stones we have to concentrate on? Post-medical. Number one,
chronic
DM.
diseases.
Number one is DM.
Hypertension.
Diabetes mellitus. What is the value
gout.
of, yes, diabetes mellitus? What is the value of diabetes mellitus in a case of stone? In the case of diabetes mellitus, there will be renal impairment. This renal impairment, what happened in the kidney? What happens to the papilla of the kidney? Sloughing of these papillas, sloughing of protein of the kidney, accumulation of this with the crystals will form mucoproteins, stones. These mucoprotein stones are more common to be seen in diabetic patients. So diabetes mellitus, number one. Number two, which lead to this, yes.
ممكن الاشياء اللي بتاثر على الالكترولايتس هايبرباراثيرودزم او دايابيتس انسيبيلس اذا بدها تعمليها هايبركالسيميا.
So about thyroid and parathyroid function, very good. GI, you will ask about gout, isn't it? Of the medical diseases. And yes, very good. And malabsorption. You will ask about inflammatory bowel diseases like Crohn's disease. So there will be malabsorption of minerals. So it will, they are prone to form stones. So this is in the medical history. Now, surgical past history of the patient, we will ask about operations. One of your colleagues said, I will ask about appendicitis. That's right. Why? Because it might be urethric colic, not appendicitis from the beginning. This is very good question. Now, urological past history, we will ask about what you have done to this stone, any operation or no operation. That's nice. Then we come to the drug history. The drug history, the drugs which you mentioned, excessive use of diuretics, excessive use of ciprofloxacin, excessive use of endeavour drugs for HIV and these things. So this is the drug intake. Now, the family history is important. You will ask not only about the parents, we will ask about brothers, and we will ask about children also. And how relative he is to his wife. They are from the same family or not. So this is important in the family history. And what else is important in the personal history? Any urological case, we will not be satisfied in the history taking unless you ask about personal thing. From the personal history, habits. What is that? Arwa, Bayan,
maybe smoking.
Ahmad. Smoking, excellent. Excellent, smoking. Smoking is very important to be asked about, especially in urology. Why? Because we think this is precancerous to the kidneys and urinary bladder. That's why always this is part of any history taking. In urology, you have to mention about habits. The major habit is smoking. Should be mentioned always. And something else also is important in urology to be asked about uremic symptoms. Uremic symptoms, because you see that renal stones might complicate the function of the kidney, isn't it? So it might cause renal impairment, or it might lead to renal failure even. So what are the uremic symptoms we need you always to mention in the history of any case of urinary stones?
Acidosis.
Symptoms, uremic symptoms.
ممكن
Clinical picture,
البريذنج
the patient.
البريذنج عشان بصير عنده acidosis.
Yes.
Vomiting.
Clinically, how he will be manifested, what a symptom he will tell you, and you have to mention it in the history whenever you present a case.
Pain during while passing urine, maybe.
Uremic symptoms, the major uremic symptom we have to mention is headache and lassitude, feeling unhappy, feeling generalized weakness. So this is the major uremic symptom we need you to mention. Always headache, lassitude should be mentioned in the history of these patients, should be positive or negative. Clear?
Yes, clear.
Okay. So these are the major things which are needed in the history taking and general evaluation of a patient of urinary stones.
Doctor, maybe sweating.
Yes.
Sweating and palpitations نسألش عنهم.
نسأل.
ممكن يكون لهم علاقة بال.
Yes, it will increase the concentration of minerals. Sweating. Yes, you are right.
مشكور
Very good
دكتور.
question. Very good question.
دكتور طب الديابيتس insipidus كمان ممكن
تسبب؟ Yes, it can cause. Anything losing of fluids can cause. Chronic diarrhea can cause. That's why we ask about Crohn's and inflammatory bowel diseases. Any cause making loss of continuous fluids of the body is a predisposing factor and precipitating in stone formation, because it is equation about fluids and minerals. So it is a solvent, and it is just like chemistry. Precipitation of minerals due to the less fluid, so precipitation will be more. More water, so the concentration will be less. So there will be no chance for precipitation. It is a chemical formula. Happy to be with you, Muhammad, and I wish I will meet you again.
مشكور كثير لك، يعطيك العافية.
يعطيك العافية دكتور. شكرا.
باي.